Hi again and welcome back. I'm so pleased to welcome Adjunct Associate Professor of the University of Notre Dame and National Medical Reporter with ABC News, Sophie Scott, to facilitate this panel session. If you missed her yesterday, Sophie is an award-winning medical and health journalist, including an Australian Museum Eureka Award and multiple awards from various professional medical colleagues. Sophie's reports appear on the ABC News, the 7:30 program and ABC Online. She's been a guest host on RN's Health Report and is a frequent guest on Richard Glover's ABC Sydney Drive program. She's the author of 2 books, Live a Longer Life and Road Testing Happiness, and writes a popular blog on positive psychology. Thank you, Sophie.
Oh, it's a pleasure, Julia. Look, thank you very much. And we had a great session yesterday, and I'm sure today is going to be just as informative and fun. So thank you, everyone, for being here. We know the theme of the conference is response, relevance, and reliable, and that's some themes we'll discuss in this session as well. As we talked about in the panel yesterday, we know that activity-based funding for hospitals has been a success, but that it does need to be tweaked, and we'll be talking about that in our session today. Now, if you're on social media, we would love you to get involved and be tweeting photos. So the Twitter handle for IPA is IHPA News, and mine is Sophie Scott and the number 2. If you're on LinkedIn, it'd be great for you to share some images and photos from today. Again, it's the Independent Hospital Pricing Authority. And if you're on Instagram, my handle for Instagram is Sophie Scott and the number 2. And I post a lot of content on Instagram these days. So if you're on Instagram, we'd love to see you over there. The hashtag for this panel and the conference is ABF21. And don't forget to tag IPA in any of your tweets or posts, so that way they can see what you're posting and repost it. So the purpose of the panel today, this particular panel, is to look at the perspectives from state and territory health department leaders on the challenges and opportunities that exist in light of the addendum to the National Health Reform Agreement and how to improve the value of activity-based funding. We have a great panel for you, slightly different to what might have been in the original program, but very eminent and informative nonetheless. So first of all, we have Elizabeth Koff, who's the Secretary of New South Wales Health. She's held a number of senior executive roles within New South Wales Health, and as Secretary of the Health Department, she's responsible for managing the health budget of $29 billion and setting the strategic direction for New South Wales to provide exceptional healthcare research and education. So welcome, Elizabeth. Thank you for your time today. We have Lynn Cowan, who's the Deputy Chief Executive of Commissioning and Performance in the South Australian Department of Health and Wellbeing. And as Deputy Chief Executive, she leads a range of areas with the local health networks, including commissioning, purchasing health services, funding, safety and quality, and also implementation science. So welcome, Lynn. Thank you for your time today. And a couple of changes. Carolyn Edwards was unable to join us, but instead we have Fifine Cahill. She's the Assistant Secretary of the National Health Reform Branch of the Federal Health Department. And this role has key responsibility in managing the National Health Reform Agreement, as I'm sure many of the audience know, is the key mechanism for the federal government for their funding of public hospitals. And her branch also manages the national COVID-19 response. So welcome. We really appreciate you being with us, Fifine. It's great that you can make the time to be with us today. So, and unfortunately, Nick Steele was going to join us, but he is a last-minute apology and sends his apologies. So welcome, everybody. Now, for the audience, we are going to be taking questions from the audience. There's a live, you'll see at the bottom, the live Q&A box. This is where you can write your questions, and I'll be looking at those as we go through the session and picking out ones to answer for the last, say, 15 to 20 minutes. So if you do have questions, please put them in the Q&A box. We'll try to get to as many as we can as the session goes on. It's a great opportunity to ask questions to some people that you probably may not get access to generally. So I urge you to take advantage of that. So we're going to be talking about activity-based funding, and it's a great opportunity with the panel we've got to look at how the states and territories are, maybe tweaking things as the as the rollout of activity-based funding, changes as we go on. I want to start by asking the panel, activity-based funding has been criticised at times for rewarding activity, hence the name, activity-based funding, and ignoring other aspects which are important for high-quality care, such as prevention. And I want to ask, how is this being tackled at a state and local level? We might start with Elizabeth first.
Thanks, Sophie, and delighted to be here, and thank you for the opportunity. And it's a pleasure to not be talking about COVID or vaccination for a little while. I know it's probably what's preoccupying everybody else. The comment I made when IPA first asked me to speak, I said, you probably haven't got the right person with detailed knowledge of activity-based funding to talk at your conference. And they said, no, you're just the sort of person we want, because obviously activity-based funding is an incredibly important tool that we use to run the health system in terms of purchasing services from the districts, negotiating with Treasury on our funding envelope, and obviously as an essential part of the National Health Reform Agreement, because that is the foundational element where the Commonwealth funds come to the states and territories for the operation of the hospitals. So it would be fair to say New South Wales was one of the latecomers to activity-based funding, and it was only after the signing of the original National Health, or the most recent National Health Reform Agreement, that we used it to purchase services from the hospitals and the districts across New South Wales. Prior to that, we had what we called the resource distribution formula, and that was always more predicated on population size of districts, on the equity factors, health equity and socio-economic gradients of those populations, the aboriginality of the population, etc. So it took a more comprehensive approach, I think, in incorporating some of the social determinants of health in allocation of health funding and resources. And from my perspective now, that's one of the key things that's missing. If we really genuinely believe in equity of health outcomes, I don't think activity-based funding actually comprehensively in any way addresses how we manage health equity across the system. I guess the second thing from the perspective of activity-based funding, it doesn't reward necessarily good outcomes of care. And that's something I think we did in the last National Health Reform Agreement, to look at penalties for complications or comorbidities associated with an episode of care. But in that sense, it definitely did drive more volume of activity without a real lens on what the quality of the outcomes we were obtaining. And the readmission rates and those sort of things are indicative that sometimes we incentivise another admission to hospital rather than providing a high quality service at the outset. The other thing just then for how we do encompass prevention and population health and those sort of things, it's not adequately covered by activity-based funding at all. And despite the fact that I said it's nice to talk about something other than COVID, I think the recent pandemic has highlighted the need for strong public health services across jurisdictions that had the capacity to respond to the pandemic, and the ongoing investment and delivery around those services has never been so apparent as it has during the COVID pandemic. And I think from the New South Wales perspective, we've had a continuous investment in population health services and commitment to capability and development of staff that I think has been very important in our response to COVID.
Oh, look, thank you, Elizabeth, and we'll follow up in our next question to talk about maybe some specific examples of things that are happening in New South Wales to tweak activity-based funding, or to bring in some of the other issues like value-based care and higher value care. But we'll move on to Lynn next to ask you the same question about the fact that activity-based funding does tend to reward, activity, and how is that being addressed in South Australia so that it can look at other things other than just rewarding activity and simply having people in hospital over and over again?
Look, I think activity-based funding is actually just one of the tools that we use, that we can benchmark about what certain services cost, but it actually isn't comprehensive in the way that we deliver services and as services mature. So I think what we need is a complete management tool, and I absolutely agree with Elizabeth, is that we really do need to use it as part of what we deliver and how we plan and how we actually allocate money across the system. It is absolutely no point if we're delivering, we've got high variation in one area because activity is the driver of actually getting revenue into your local health network. So for us we use it as part of the tools, and we're really maturing it in South Australia. We allocate our activity based on, activity-based funding, but we do use the basis of population area of need to do that. We're moving into using PROMs much more, and we're actually driving that. And we're also looking at low-value care. So activity-based funding actually does allow you to do that. And actually what we need as a system as it matures is to work through how we disincentive and may not pay for those types of services as we move forward. So I really agree with what Elizabeth is saying. I think COVID has had some real positives about actually how we do look at our system, and absolutely agree with you. All of those services that we've needed to put in place that are actually outside of the funding model has been enormous. And it has actually demonstrated to us is that we can't just look at it activity-based funding. We actually need to look at holistically across both primary, secondary care to actually deliver services to our communities.
And so, Lynn, before we move on, I might just get you to expand on what you were saying about PROMs and explain. I'm sure most of the people in the audience will know what that means, but I might just get you to explain that just for people who may not know what that means, and maybe how you're using that in your health department.
Yeah, so we've just started a project of PROMs and PREMs using our new commission that's been established in the last 2 years, is to actually use evidence of outcomes and actually having outcome-based care for our community. For a couple of reasons we want to do that is it allows us to have more conversations with our consumers to say, actually, what was the outcome for you? So not just that I've had my hip replaced and, off you go. We actually want to know what impact it's actually having on the individual. So for me, it is more around allowing us to have the conversation about outcomes of care and actually having that as part of our whole systematic review. And we're on that start of the journey now. So actually, South Australia's gone through an enormous restructure. We were probably the last jurisdiction with not having boards in our local health networks. That's allowed us as a department to step back slightly and say, actually, what is our role as a system leader or system manager in that process, and actually how do we add value to each of the local health networks. So I think actually us having that in place has now allowed us to start saying, what are the tools we need to ensure that we're having good outcomes in our community.
Okay, excellent. So, Fifine, we might move on to you next. So, from a federal point of view, what's your feedback and input when it comes to activity-based funding and the fact that it does tend to reward activity and maybe not look at things like prevention and patient-based outcomes, things like that?
Thanks, Sophie. So I think I would really agree with the comments that Elizabeth and Lynn have made. Incentivising activity is in many ways a strength of our system. It does reflect the real commitment we have that when a patient comes to a hospital in Australia, public hospital in Australia, we try really hard to actually deliver an activity to them, but making sure that that's the right activity and thinking about what things we want to incentivise that aren't captured by activity-based funding, I think we all agree is really important, particularly as we try to build on the strengths of our system to make it even better. And I'm sure it's not news to anyone who's been following, but the latest addendum to the National Health Reform Agreement, which was signed kind of in the middle of the COVID pandemic and took effect from 1 July last year, does reflect, I think, some really promising commitments from all governments to look at what is the next stage of health reform to make those systems work even better, and I think to address some of the issues that both Elizabeth and Lynn have identified in terms of activity-based funding not sufficiently accounting for outcomes, the need to look at how we might do better local planning and integration of services, which is really important, particularly as we see the growing impact of people with chronic and complex conditions and many people who need services even beyond their health system, and how do we make those services work more effectively together. And also looking at, as Elizabeth was rightly saying, how do we think about prevention and social determinants and building better equity into our health system. As my colleagues who work in Indigenous health will remind me, that having a great activity-based funding measure isn't much good if people don't have access to the service, then we have activity to measure. So I think, you know, we're all sharing that view that there are great strengths of that activity-based funding system, and it works really well for some areas, but there's definitely room for improvement, and we're all keen to work together on that. And I guess I would probably also look at the experience through COVID to say, while it's definitely, as Elizabeth pointed out, has shown us the critical role of public health, I think the other thing it's shown us is how incredibly flexible our health systems can be when we need them to be, and what outcomes we can deliver when we all work together for a common goal. So I'm really looking forward to us working together now to look at how we use the opportunity for reform to reach the common goal of improving on those strengths that we have in our system, and looking at how we counter some of those challenges we have.
Yeah, that's a good point. And so I certainly, from a patient point of view, I know that the fact that the system was so quickly able to move to telehealth, which was something that patients have been wanting for so long, and it happened so quickly, almost it seemed like happened overnight. And I know that's something patients are, you know, very, very happy that they had and are going to continue to have. So I wanted to just to talk about, you know, continuing on from this first question, but about what new opportunities there might be to improve the value-based funding models in line of the addendum, and maybe we'll start with Elizabeth. And I was reading some work that you had written about the value that New South Wales introduced with values-based healthcare. If you can explain to the audience what that is, and the commissioning approach that goes along with that, the collaborative commissioning approach.
Yes, certainly, Sophie. It really harks back to intense discussions with Treasury. Now, where else do health discussions start with Treasury? And the intergenerational report that was done in New South Wales indicated the extraordinary growth in the health budget if we kept operating the way we're currently operating. And I think it's a concern for every state and territory and the Commonwealth that the health budget cannot be unlimited. And that's the first issue. We're currently about 32% of the state budget, but, you know, the modelling showed we could easily spend 100% of the state budget if we tried hard. So that's the first thing that I think is high on people's consciousness. The second thing also is there's so much new technology and therapeutics on the horizon that are extraordinarily expensive. And the expectation then that every new drug and every new gene therapy and every new piece of equipment that can advance medical treatment will be able to afford and manage is really quite unrealistic. So it posed the fundamental question that what really do we aspire for a health system and what should be important? So we went down the path of value-based healthcare, and from my perspective, value-based healthcare is a long journey. It'd be nice if we could decide overnight that we're a system that's a value-based healthcare system, but there's so many enablers that we need to put in place to start moving the system to understand that it's genuinely delivering value both to the patients receiving care and the clinicians providing that care and delivering good outcomes. So we've been slowly progressing some initiatives, and I must admit, COVID did cause us to go into hibernation with many things. We were struggling to just keep up with the demand of what we were doing, but we had some extraordinary successes in developing some value-based healthcare initiatives that, from my perspective, really represent a sound investment of health funds. One of the favourites that I have in terms of the program is the diabetic high-risk foot clinics. Amputation rates from diabetes are very high, and also in the Indigenous population, they're disproportionately high. And the fact that there's demonstrated evidence that high-risk foot clinics can reduce amputations, and why we didn't have one in every concerned me. So we had a strong investment from clinician input in how that would look like, what it would look like. We've got good evaluations, good economic modelling around those things, and we're hoping we can deliver long-term benefits from programs such as diabetic high risk, the osteoarthritic component of hip replacements we're looking at. So we've got a range of programs on foot that really we believe can drive value. But at the heart of the value proposition, and that's why I emphasise we're not there immediately, is the outcomes that matter to the patient. So we don't have well-developed patient-reported outcome measurement systems, PROMs and PREMs. We don't measure the outcomes there. So we've really had to also realign the system to have the capacity to measure those things, to ensure that we are getting the outcomes that matter to patients and the outcomes that matter to clinicians in delivering the care. So it's a comprehensive suite of initiatives we have in value-based care. But from my perspective also, the final point that I'd make, the discussions we have with clinicians and patients are different to the discussions we have with treasuries. And treasuries want to drive productivity, want to drive efficiency, and want to attempt to reduce the health budget. The most important messaging that we give the health system, we're not looking at cost cutting, we're not looking at taking money away from the health system. We're looking at optimising the use of our resources so we can deliver care and modern technology and drugs to a far greater range of people.
That sounds great. So we might move on to Lynn, and I'll just check, I'll just double check with the audience. Oh, now you're back. There you're back, Elizabeth. That's good. So Lynn, just from South Australia's point of view, that was very interesting hearing from Elizabeth about the values-based approach that New South Wales is taking. Is there anything you can share with the audience about any initiatives in South Australia that you're either looking at or hoping to introduce in the future?
Yeah, look, we've been looking at New South Wales and the work that you've been doing. I think we've got one of your health economists that's come across to us, so which has been fantastic. So, and we've been investing in the health economist part of our business. So that's been terrific. But we're in the very early stages. I think the first part we've started to look at is actually low value care. Is actually what does not give good outcomes and what is not the right delivery of services. But I agree with Elizabeth, it isn't actually about saying, actually, we're just going to remove all of that funding from your budgets and now you should no longer do that work. It's actually a long journey because you do need alternative pathways, and those pathways also need to be funded. So for me is, I think we did the largest amount of knee arthroscopies in the world in South Australia at one point in time. There wasn't not evidence of outcomes of actually if they were actually having any improvement on outcomes. But what we do need to do is invest in the prevention. So pathways, alternative pathways, you just can't remove a whole service and say, actually, that's not providing care for the patient. It is actually working with clients, patients and clinicians about what is the new pathway we need to take. And that is a journey we need to go on. And sometimes the funding models do not support doing that. So we're really spending a bit of time. We did a bit of a shadow year last year. It's allowing us to have greater conversations with our local health networks about what is low value care and what are we seeing in the data. So we're at the very beginning of the journey. So we're going out, talking to people, talking to the LHNs and actually working through that way to get a better outcome, and agree that the technology and the drug development and the genetics is far greater, moving at a far greater pace than actually our funding models and even our funding from Treasury, that we're going to have to keep up with it and we're going to have to get much more sophisticated in our approach. I'm a great advocate of actually learning from the other jurisdictions. I think it's a really good opportunity for us to work together and actually try and, because there's huge amounts of investments in new systems and new ways of measuring, so that we should be doing that together.
Exactly, that makes a lot of sense. And you know, rather than trying to reinvent the wheel, if you can see that something's worked well in one state or territory, to incorporate that, it makes it a lot easier. And I remember, Elizabeth, I did a story about a program that was introduced at Royal North Shore Hospital, where it was people on the waiting list for knee replacements, where instead of, which was very successful in getting people off the waiting list, they gave them a very holistic access to physiotherapy, dietary advice, exercise physiologist. And basically what happened was a lot of quite a large percentage of the people who were on the waiting list for the knee replacement didn't end up needing it in the end. Yes. Because they were able to get funding for all these other services. A lot of them lost weight, became a lot more mobile. Their arthritis improved. They didn't actually need the knee replacement in the end, and that was a great model for showing, and it was funded, and to show that you could, if giving people access to the patients access to the sort of services that they really wanted, meant they didn't end up even going to hospital to have the knee replacement. So there are certainly some very unique and interesting models out there of care. I might just ask Fifine about, from a federal point of view, what are the sort of initiatives that you would like to see the states introduce, or that you've heard of, that you are interested in and would like to see more of, to ensure, particularly with either the value-based funding model or getting rid of the low value care?
Yeah, I mean, in many ways, I think our role is a little bit on the macro level of what Elizabeth and Lynn both talked about, in terms of reassuring physicians and health services that we can change what you deliver and improve the value for patients without making your service suddenly unsure about what your budget's going to be. And I think in a lot of ways, our key role, particularly where I sit, is at looking at how we make sure that as we can support with Commonwealth funding through the National Health Reform Agreement, adjustments so that those kind of changes of service models don't result in unintended consequences, where you've had a really successful intervention that keeps someone out of hospital, and then suddenly your hospital's not getting the revenue from that activity and the hospital's got a problem. But we actually want the hospital to still be fully staffed and have the people, but maybe they're doing something slightly different. So a lot of our role is really about not telling the states what they should be trialling, because we're not running those systems, but really looking at how we make sure that the way the funding flows doesn't create a disincentive for trialling those kinds of options, and that we can adjust the funding model to recognise different ranges of services that need different types of people and maybe different kinds of ways of delivering. I think, interestingly, post-COVID, I'm really curious to see how much healthcare goes back to actually being delivered physically on-site in hospitals versus the kind of telehealth that you referred to, and other options that we have now had to explore. But really, I think making sure that we can balance, obviously we also have a Treasury who are is concerned about our expenditure, but we also want to make sure that we're not creating kind of unpredictable flows of revenues for states and territories and for public hospitals, so that people can go forward with confidence to try to implement. And I think the other thing, again, drawing really on what Lynn was saying, is that we're really keen to look at how we help scale up. So I think we've seen lots of really successful and exciting small scale trials of different models of care and different ways of doing things. And some of them have had really great outcomes, but the scaling up and they're really embedding them into the system, I think, is a real challenge. So we're like really keen, I guess, to look at, well, what can we do at a national level to help all jurisdictions to learn from each other and to speed up that sort of embedding into the system process.
There was an interesting program that I was reading about in New Zealand, and it talks about the prevention's obviously one of the issues that that we want to see as the system evolves. And we know with this the Canterbury Model in New Zealand, and I'm just interested from the panel if they're aware of the Canterbury Model. And from my reading of it, it sounds like it's a very person-centred or patient-centred approach, where GPs are paid to manage patients and work with specialists. The funds are based on patients' health outcomes, and there are things like more 24-hour clinics and resources for GPs. And a study of this Canterbury Model found between 2007 and 2014 that there was a 11% decline in people going to hospital through that model, which I found very interesting. And I guess you need to make sure that if people weren't going to hospital, that the hospitals weren't necessarily losing out. But I just was interested in that approach, because whether that would work in Australia, and whether you're aware of any states sort of trialling anything like that. Elizabeth, are you aware of anything like that?
Sort of the basis of what we've done our collaborative commissioning trials. So you did mention that earlier, Sophie, and I skillfully navigated away from it, but I'll come back to collaborative commissioning. Look, one of the key elements in the National Health Reform Agreement that we prosecute regularly at most of our what used to be RMAC and COAG meetings, which now have a different name because they don't exist anymore, was the primary care hospital interface, because there is a disconnect in the system between primary care and the hospital system. And many attempts have been made over many years. We were reflecting, because we're publishing an article soon in a journal, hopefully, that looks at coordinated care. Back in the days, that was trialled many years ago, about pooling of resources, etc. But our collaborative commissioning model really is reliant on working with the PHNs and GP practices as equal partners to pool some resources and identify cohorts of patients where we can deliver care that really hopefully maintains them in the community and provides them with ongoing support, be it specialist consultations or the primary care that they need, or the community-based healthcare that they need. We have large resources invested in community healthcare in New South Wales. My issue with community health-based healthcare, that is the future, and that represents where we'll deliver more healthcare. But if I speak frankly, we haven't industrialised community-based healthcare like we have inside the hospitals. We can count things with case mix, we can do all the things, but the sophistication of community-based healthcare is not as great as what we do in the hospitals. And I really think we need to organise ourselves more coherently to maximise the benefit of those. The common example that often is given in New South Wales, that you potentially have the 9 o'clock 9 a.m. series of cars parked outside as you get the diabetic nurse to come and visit, and then you might get the wound dressing nurse to come and visit, and then you might have the community nurse to come and give you your medications. We don't actually integrate our own community health services well. And our collaborative commissioning model is trying to change the landscape to orientate the services, be they primary health, hospital, specialist and community-based, around what the needs of the patient are. So we're in the early stages of that, and we're ever optimistic because something needs to change and everybody's grappling with how we change that interface.
Because like at the moment, it's the patients having to navigate across all the different systems, and that can be fine for some patients who've got higher levels of health literacy, and
Yes.
But for others that can be very, very challenging. And so I'm sure from a patient point of view, that's something that people would want to see. And what about from South Australia's point of view, Lynn? Is there anything similar to that Canterbury model, or that more integrated model between different parts of the system?
We're probably not as far along that journey as they are in New South Wales, but what we have done is we've created an attached office called Wellbeing SA, which looks at primary prevention and its linkages to the primary healthcare. We also invest a lot of money in the community, in community-based programs, but again, we need them integrated into that process. We're in the midst of rebalancing our system. We had a very hospital-centric service in South Australia. We've now got external providers who are set up to deliver our home hospital and community-based services. We're doing that through the attached offices that are actually having the conversations with our local health networks and providing that navigation role between both. So we're growing that. In addition, we've set up what we call PCCs. They're GP practices that have significant diagnostics. So what we're doing is we're reorientating our ambulance service, that for those people who meet certain criteria will go to a PCC, not to an emergency department. And we're working through what that looks like. That may include seeing somebody, doing the diagnostic and sending them home, or doing a partial workup and sending them to the emergency department. So it's sort of bringing both the GP practices as well as the hospitals together. That is not coordinated care, though. That is just an alternative pathway, because at the moment every pathway seems to go to an emergency department rather than to a GP practice. So we're at the very beginnings of what that looks like. We're about 12 months in. We also need to industrialise those to get those numbers up to a reasonable level. We're also developing some pathways where we actually work with our residential aged care facilities, so that we can actually keep people in situ, not send people to emergency departments, and actually manage them in the community much better than we do at the moment. So really nice integrated processes around that. But we're at the very beginning, as I said, of these journeys as we're moving forward. But actually having an attached office that's not in the department, not in the local health network, that can actually spend all of their time looking at primary prevention and primary healthcare interfaces, actually allows us to move it quicker than we normally would.
Oh, that sounds interesting. I would be very interested to find out how that goes. So what does PCC stand for? Is that primary care centre?
Primary care centres. So there's two pathways in at the moment, so we don't actually have walk-ins. It's either through our ambulance service or through the emergency department. So you might get to triage. The nurses will say, actually, we think you can stay with us for the next few hours, or we can get you straight into the PCC. And what's really interesting, in some of our local health networks, that has actually taken off enormously, and they turn over quite a large number of people on a day-by-day basis to that.
Oh, that's very interesting. I would love to hear more about that. Before I move to talk about sort of the federal view of these different things, I wanted to another interesting program that I was reading about is the Victorian Health Links program. And this is, because unplanned readmissions is obviously something that's, top of mind for people, given that's going to be a criteria to look at soon with activity-based funding. The Health Links program identifies people with chronic illness at high risk of more than 3 unplanned hospital admissions, and patients are given a much greater level of telephone support and counselling and coaching after they leave hospital to, hopefully prevent them from coming back. And I just wanted to ask both Elizabeth and Lynn what you thought the advantage of that sort of system would be, and whether there was anything like that being trialled that you were aware of, and whether that's something that you think could have value in your jurisdiction. Elizabeth?
Look, Sophie, I think it's something that we all do, and we potentially call it something else. We had a chronic disease program, similarly, multiple admissions to hospital, more intensive intervention and follow-up at home. So I think lots of jurisdictions have done variations on a theme, number one, and it'd probably be useful if we got some consistency of nomenclature, I guess, at the end of the day too, because that's what makes some of these models very hard to describe, because they're all variations on the theme. In terms of hospital admission avoidance and better, combined with better care in the community. The one big comment that I'd make though, and the Productivity Commission is putting out a report about some of these models, and they've addressed HealthLink and our collaborative commissioning. Sorry, Lynn, I don't know whether they've mentioned your SA one, but one of the biggest issue actually is the data sharing. And under previous RMAC, we did some trials. We started data sharing MBS data with hospital admission data and linking that, and that provides extraordinary insights into the patient journeys. And we've through signing up with the Health Reform Agreement, Fifine, you might not be aware, we did a data exercise called Lumos, where we can sign up GP practices and integrate the data with our health system data. And the insights that is providing us about care is extraordinary. Some GP practices had no line of sight that their patients were having a hospital admission, and some of the hospital admissions, we discovered if there's a follow-up within 7 days from discharge from hospital with their GP, an extraordinary increase in then non-admission subsequent to that. So the GP visit really helped them in managing them home with community support, and their readmission to ED was reduced. So I think one of the big differences that will make a difference to all these programs is the accessibility to data and using real-time data to inform the clinical care that we're delivering, because it's not any use to us 6 months afterwards that we see patients had these journeys that were quite poor. If we can act with some immediacy, all the clinicians involved in the care can make a difference.
And Fifine, I might just ask you on those points. So we've talked about the prevention, and we've talked about keeping people out of hospital. What's what from your point of view when you hear about these models? What are the sort of things that? What's your feedback to these different models that you're hearing about, and from a federal sort of health point of view?
So actually, Elizabeth, you're lovely. People have been talking to us about Lumos and about collaborative commissioning, and we're very excited. And I think I was just reflecting as you were talking there on the value of contemporaneous data, and I think that's another one of the lessons we've all had from COVID, is that data about what's happening now that we can act on is so much more valuable than data that's maybe beautifully, carefully curated and slightly more accurate, but is too late to do anything about. So I think we're all really keen to work certainly on looking at how we can make share Commonwealth data more proactively and in a timely way, and also how we can build on those sort of actionable data sets so we all can have insights into what's happening in the system and make decisions about where things are working well and where we need to make changes. And I think that's going to be a big area of work going forward. And now I've forgotten the start of the question because I'm.
No, it was just really just getting getting some feedback from you from the federal sort of point of view when you hear about these different models and these different things that are being trialled, what you're interested in, and what from a federal sort of an overview, national overview, the sort of things that, well, obviously this the Lumos one, which was on my list to ask about, which sounded very interesting. Are there other models and other things that you've been, that's sort of on your radar, I guess, that we might not have discussed so far?
Look, probably health links was certainly on our list as well. But I do think one of the key things here as well is getting the evaluation. So really keen, I think I've been assured that Health Links is currently having a really good evaluation done. I know for the collaborative commissioning that New South Wales is doing, they've got a really robust evaluation methodology built into that from the start, which is fantastic, because I think it's the evaluation and then the evidence of what works that gives us the basis then to have conversations, including with our delightful colleagues in Treasuries, about something actually works. This is what the difference is that it makes. This is why it's something that we should all be collectively looking to invest in. And without that evidence, it's really difficult. But I would actually agree with Elizabeth again that having some common ways of describing what it is that's happening, because often I think there is a bit of confusion about things. And I should also note on Health Links that is currently actually funded through the National Health Reform Agreement processes. So it has been our kind of demonstration project that we can find more flexible ways of funding things through the system that we have. But I think we're really keen to see that go further. And that, again, I think is something that Elizabeth's collaborative commissioning people are keen to talk to us about.
And Fifine, just before we move on, when you mentioned evaluation, and this is probably interesting for people who are looking at setting up programs or systems, what sort of evaluation that would be ideal? Is it purely, or I guess you'd want to be looking at evaluating a range of different outcomes, but can you just talk about what sort of evaluation would be of the most importance?
Yeah, so obviously the first thing that you always want to see in an evaluation is actually what is the impact on patient outcomes. And I think it's really good to have both those objective measures, but also increasingly those prems and proms that have been referred to earlier about what was the patient's experience of care and how does the patient feel about their outcomes. Obviously then we're all interested to understand how different interventions affect how patients flow through the system, and what the resource use is and how it's different in different parts of the system. And again, that's an area where it's really important that we link up the data so we can see, you know, does a primary care intervention that's funded through the Medicare system then affect what's happening in the public hospital system, and vice versa? How do we then make those systems work better together? We really need to understand that. And obviously, certainly from my perspective, I think cost effectiveness is really important. So we really need to make sure that if we're funding something, if it costs more, it has to deliver more. And if it delivers better, then that's, you know, what we really need to aim for. So
we've got about 11 minutes on my clock, so we've got quite a few questions. So I might just try to get through as many questions as we can in the last 11 minutes. So we've got one question from Darren Elliott, who asks, is the division between federal funding, so primary care, and state funding one of the main drivers behind the siloed mentality between hospitals and primary care? And could the panel comment on whether this funding could either be centralised to one, say like he's suggesting like the NHS, or decentralised to a state level? He's asking, is this a pipe dream or is it unlikely to change some of the silos? Maybe might go to Lynn first, because I haven't heard from you for a moment. What do you think about this suggestion?
Look, it's really difficult in a federated system. I mean, to actually change a system whose large and complex as we have, you know, it would take a long period of time to do. It doesn't mean, though, that at a local level we can't do more work together. And I think, you know, your commissioning collaborative in New South Wales is one of the examples where you do that. How do you find the middle ground in that without actually having a total reform of actually how whole systems are delivered? You know, everything from GP practices, they're set up on a business model that is Medicare billed in those processes, through to how hospitals and both state funding for hospital activity, but also community activities. So the states don't just provide funding to us for hospitals, they actually do provide us funding for a whole lot of other services around those things as well. I think it is I think it would be a reasonably long journey, and you'd actually have to have governments at both the federal and state level to change that whole process.
Okay. Elizabeth, did you have any comments on that before we move on?
Look, it has been mooted, Sophie, and I think the last time it was in the health reform when Rudd was Prime Minister. And, the options are Commonwealth take it all, state take it all, and nobody's willing to take it all. And the good old vertical fiscal imbalance issue of the Commonwealth government can only raise taxes and then states limited by revenue. It's way too much of a world of pain. What I came to the conclusion about, and this is what we did with the collaborative commissioning, we're never going to change the structural issues that have been entrenched for many, many years of funding, etc. So let's figure out how we can work together, make those changes. And from my perspective too, the arguments of cost shifting over the years, it's not the place to start to having a discussion about a new service model. And given the Commonwealth still is on the hook for 45% of hospital growth and still funds quite a proportion of hospital activity, we need to figure out to park the dollars from my perspective, though Treasury probably wouldn't like me to hear that. Let's get the model of care right, and then let's understand the dollars associated with it. Because if you start at the outset of a conversation about you fund this bit, I fund this bit, but you're not funding this bit, or you're shifting this, you don't get anywhere. So it's in the outcome with the patients.
So we've got another question that's interesting from Luke, and he's asking, acknowledging that the health system is flexible, as we've discussed, the addendum to the National Health Reform Agreement agrees to joint planning and funding at a local level, and he's asking the panel, how can it be better adapted to the needs of rural and remote areas, which often face workforce shortages across both primary health and the hospital system? So I'd be keen to ask briefly all the panelists to get their view. Maybe with Fifine to start on that one.
Yeah, thanks, Sophie. So this is an area that we actually have been doing a lot of thinking and talking about. I haven't quite got to the point of trialling something yet because we were all slightly busy. But I think there is a lot of interest, particularly in rural communities, to look at whether there are more flexible ways both of setting up some governance around their local health system, of understanding what the funding flows are, and of thinking about how you might better leverage those funding flows to support local employment of a range of health professionals that you need to deliver the services. And I guess the example that really resonates for me is when you look at an allied health practitioner, like a physio, who might be in a rural area. There's work for physios gets funded through the local public hospital where they're delivering services that might need rehab, through perhaps the local residential aged care facility might need some help for their patients, through the National Disability Insurance Scheme where they'll have clients who might need a physio, through Medicare that also funds services for people with chronic disease who would benefit from physio. That's a very complicated set of funding arrangements for an individual health practitioner then to structure a business that lets them deliver services. So I think there's a lot of interest in saying, well, is there some way that we can make it a bit easier for those practitioners to deliver the services that we all want them to deliver to that existing client group using the funding that's currently available, but can we make that just a little bit easier for them? and that's then, I think, not limited to physios. There's, you know, the same issue arises, I think, for many different types of practitioners, and also the issue for patients and clients who need that service of, well, how do they access the service and why is it different depending on why you need your physio? Because, of course, you know, people in residential aged care also access services through lots of other parts of the system. So it's a very active conversation at the moment. I think with just trying to work out, well, what might the practicalities be, and how might we organise that? And I do think governance is certainly an issue that comes up a lot, because, like, what is local governance that needs to be in place to make sure that whatever new arrangements we have really work both for the people and also for the professionals who are delivering those services.
Oh, thanks. Thank you for that. I might just ask Lynn and Elizabeth if you have any comments to make on that, on the regional and rural issues as well. So I think it's something that every state and territory grapples with. Elizabeth?
Look, it's an extraordinarily challenging area, and we have a parliamentary inquiry on rural and regional healthcare in New South Wales at the moment. A couple of comments that I've made. I think the nature of healthcare delivery has changed so much. We actually need to have the conversation of what can you expect to be delivered in rural and regional facilities. Health has become so subspecialised. I think there's a longing for the days where the GP could do everything in the local hospital, from deliver your baby to fix a fractured arm to you know, do a gallbladder operation. They expect the world as used to happen in the generalist days. So that's the first thing that I think we need to be conscious of. The second thing is the workforce is extraordinarily problematic, and that's what Fifine was describing. We've got a pilot at the moment in Murrumbidgee local health districts where we working with the Cwlth employ some of the GPs, rather than the GP having to be a small business owner that has to rely on fee-for-service income, run up to the hospital on the hill to deliver some services, and then not see patients in their fee-for-service practice and run back to the practice. So we really need to make it a far more attractive option for all categories of healthcare staff to deliver services in rural and regional areas.
That sounds interesting. We've only got about 3 minutes left, so I wanted to ask Lynn if you had any comments on the rural and regional issue before we sort of wrap up.
Focuses for next financial year. We've got a separate workforce strategy that's actually being delivered out of our rural and remote unit at the moment, is actually looking at what is our workforce. Our workforce, as eloquently described, often work on NDIS, primary providers in the hospital, and you know, and that's just one FTE. So you know, I can't imagine what that's actually like to try and manage, and who employs them and who bills who for whom, to try and deliver services in some of our communities. I think there's two things for me, is actually how do we fund them, and I agree with Elizabeth. We've got to work out what we can deliver in some of our rural and remote areas, because subspecialisation has become more and more the norm. But also how do we fund some of those services, and how do we use technology to support rural services? We have South Australia has a lot of rural remote areas, often with low populations, but require services. So I think it is actually a whole reform piece that we need to be doing with those areas.
All right, look, we're going to need to wrap up this session. Fifine, sorry I didn't get to you to ask you about the rural and regional issue, but it's been a really interesting discussion, and I know from my point of view, I was very interested in hearing more about these new models and these trials, and it's exciting to think that there's some fantastic new things, you know, either being trialled now or that are coming up that might make the system easier for the patients to navigate. And you know, with better outcomes and more efficiency, and obviously that's something that everybody wants. But I just wanted to say thank you so much to the panel, to Elizabeth Koff, to Lynn Cowan, to Fifine Cahill, And we appreciate all the questions we had from the audience as well. Apologies we didn't get a chance to ask all of them, but it's been really great. And I know that we've had so many, if you wouldn't believe how many questions we had from the audience. So it's a very, very engaged audience out there, which makes for a very good panel. So I really do appreciate the audience asking so many questions, and I've certainly learnt a lot, and I think that the audience out there will come away understanding a little bit more about what the states are doing and from a federal perspective, what their priorities as well. And as things evolve, we'll be hearing more about these great programs. But thank you very much, everybody, for this session. I really appreciate it. Thanks for your attendance, and I'm going to hand back over to Julia now to take the next session.
Our panellists. That was the final session for this year's conference. Let's head back to the timeline to join James for his closing remarks and to announce the winners of Best Presentation and Best Papers. See you there.